السلام عليكم أبناء الطلبة. Today we will continue our first lecture about anesthesia. We teach the airway management. After induction of anesthesia and the use of muscle relaxant, there will be loss of muscle tone, so patient can no longer keep his or her airway open and usually closed by the tongue. So maintenance of airway during this period is of great importance. Also, when muscle relaxant acts well, the patient will need artificial ventilation. Techniques of airway management. We have two ways of airway management. First, the basic airway management and advanced airway management. Basic airway management include jaw thrust with face mask by using the 5 fingers of the hand. The thumb and index hold the body of the face mask towards the face, and the middle and ring fingers hold the body of the mandible towards the mask, while the little finger elevate the angle of the mandible upwards. The anesthetist can use both hands, or if there is an assistant with him, or use single hand and ventilate the patient with other hand if the anesthetist is alone. This maneuver is called CE maneuver. It's used when patient spontaneously ventilated or needs artificial ventilation for short time, like few minutes. In this picture, we see the way of face mask ventilation. This is C and E maneuver. C is the thumb and index finger, and the E is the middle, ring, and little fingers. The second way of basic airway management is the oropharyngeal or nasopharyngeal airway. It is used when jaw thrust is not enough to maintain airway, and to determine the proper size, the airway length must be the same distance between the angle of the mouth, oro, or nasal opening, naso, to the angle of the mandible. It is used when patients spontaneously ventilated or need artificial ventilation for a short time, like few minutes. In this picture, we see the oropharyngeal in picture A and nasopharyngeal in picture B. In advanced airway management, we have laryngeal mask airway. It consists of a small inflatable mask connected to a tube. The tip of the mask is settled on the esophageal beginning, while the opening in the middle of the mask will be in front of tracheal beginning. Then the cuff of the mask is inflated, so there will be a good seal around the tracheal opening, which facilitates the ventilation. Usually, laryngeal mask airway is used when there is difficulty in to maintenance airway by other means. but at the same time the air seal will not work correctly when airway pressure exceeds 20 centimeter water, and air leak will occur. Also, laryngeal mask airway will not protect against aspiration of gastric contents. Laryngeal mask airway is used when patients spontaneously ventilated or need artificial ventilation for several hours. In this picture, we will see the laryngeal mask airway. The other way of advanced airway management is endotracheal intubation. Endotracheal intubation is the commonest airway management technique used to maintain airway during artificial ventilation, and if performed by the use of laryngoscope, So the handle of the laryngoscope will be held in left hand, and the tongue will be taken from the right side. Then the blade of the laryngoscope will move with the curvature of the tongue till epiglottis appear. Then forward upward movement of the laryngoscope handle, which will elevate the epiglottis upward, so the glottis and the vocal cords will appear behind the epiglottis. Then the endotracheal tube is held in the right hand and introduced between the vocal cords to the trachea. Then the cup is inflated, and then intubation. And when intubation is difficult, fibro-optic intubation, intubating bronchoscope is used instead of laryngoscope. Endotracheal intubation used when the patient spontaneously ventilated or need artificial ventilation for a long time, even days. In this picture, we will see the endotracheal tube, laryngoscope, stellate, and the proper position of the endotracheal tube. The usual scenario is that after induction of anesthesia and giving muscle relaxant, airway is maintained with jaw thrust technique, and if not enough, we need either oropharyngeal or nasopharyngeal airway to facilitate ventilation. Till the effect of muscle relaxant is proper and the patient is lax, well, then we can either put laryngeal mask airway or endotracheal tube, according to the patient condition and the type of operation. Then we reach ventilation. Ventilation during anesthesia is required when, first, spontaneous ventilation is not enough, or apnea by anesthetics or analgesics or muscle relaxant. Okay. Ventilation controlled, we have two types of ventilation control: volume controlled and pressure control. Ventilation setting: respiratory rate 10 to 15 breaths per minute. Tidal volume 6 to 10 ml per kg. Oxygen concentration, which is called FiO2, 50 to 100% according to patient condition and type of operation. Minute volume or flow rate is equal to tidal volume multiplied by respiratory rate, which is usually 5 to 6 liters per minute. Positive and expiratory pressure are called PEEP, usually 5 centimeter water. Here we have a difference between volume-controlled ventilation and pressure-controlled ventilation. In volume-controlled ventilation, preset volume delivered and compensate for an increase in airway pressure but not for air leak, less physiological. If airway pressure is very high, there will be an increased risk of pneumothorax. In a pressure-controlled ventilation, preset pressure delivered to compensate for air leak but not for an increase in airway pressure. More physiological. If airway pressure is very high, there will be an increased risk of inadequate ventilation. After induction of anesthesia, then we complete induction, we reach maintenance. During this stage, we have to maintain anesthesia, maintain vital signs, and maintain body fluid and blood volume. Anesthesia is maintained by either inhalational anesthetics or by continuous infusion of intravenous agent, total intravenous anesthesia or TIVA. Inhalational agents maintain anesthesia through special vaporizers for each type of inhalational agent, according to their physical properties and the required concentration of each agent is added by the vaporizer as a vapor to fresh gas flow being supplied to the patient. So, the fresh gas flow will contain a mixture of oxygen, air, and anesthetic vapor in concentration that maintain oxygenation and maintain anesthesia. Total IV anesthesia or TIVA maintain anesthesia by the use of a syringe filled with IV anesthetic, usually propofol. Then we put the syringe in a syringe pump that will supply the patient with the desired dose and infusion of the drug in millimeters per hour. Also, if the effect of muscle relaxants is ended, a top-up dose can be added. During maintenance, in addition to keeping patient anesthetized, good monitoring of patient must be done and interfere with any change in vital signs that might lead to harmful effects, so hydration state is maintained by good assessment of fluid or blood requirements. After end of maintenance of anesthesia, we reach the recovery. During recovery stage, any patient, any anesthetist agent that maintain anesthesia must be stopped so the patient will be awake again. Also, muscle relaxant reversal by neostigmine or sugammadex is given to stop any remnant effect of muscle relaxant and let the muscle, mainly respiratory muscles, to return to its original power so the patient can breathe and maintain airway safely. Then extubation. Extubate the patient if the patient was intubated, or keep the patient intubated if the criteria of extubation is not fulfilled. Then the patient transferred to the either recovery room or post-anesthetic care unit, and during the transfer there should be adequate monitoring of the vital signs, and the patient must be with a secured airway with good ventilation and oxygenation, and hemodynamically stable. Here we have the extubation criteria. The criteria of an extubation include adequate oxygenation. Here the saturation will be more than 92%. Oxygen tension in plasma is more than 60 mm mercury. Adequate ventilation, in which tidal volume is more than 5 ml per kg, spontaneous respiratory rate more than 7 breaths per minute, and tidal CO2 is less than 50 mm mercury, and CO2 tension in plasma is less than 60 mm mercury. Then hemodynamically must be stable, full reversal of muscle relaxant. Here the sustained 5 seconds head lift or hand grasp. Neurologically intact. Follow verbal commands, intact cough will gag reflex. In local anesthesia, type of local anesthesia: topical, local infiltration, regional nerve block, and this block can be performed depends on anatomical landmark, nerve stimulator, or ultrasound guide. Central neurexal block, which is of two types, spinal anesthesia and epidural anesthesia, or combined spinal or epidural anesthesia. In regional anesthesia, we remember the triangle of general anesthesia, which include anesthesia, analgesia, muscle relaxant. Here we have no hypnosis. The patient is still awake, but we have analgesia and muscle relaxant. In this picture, we see the position of spinal anesthesia. The patient must be bending forward to increase the size of opening between the spines. Here, the difference between spinal and epidural anesthesia. In spinal anesthesia, we have rapid onset and short duration. The target site is to puncture the dura, and the landmark is CSF leak through the needle. Needs a small volume of local anesthetics, less than 4 ml, and usually hyperbaric solution. In epidural anesthesia, an onset is delayed, long duration by the use of epidural catheter. Target site is epidural space outside the dura, and the mark is the loss of resistance of syringe. It needs large volume of local anesthetics, 15 to 30 ml, and usually in isobaric solution. In this picture, we see how we give the epidural anesthesia. The needle is called Tahoe needle, and the syringe is a low resistance syringe. Here is the difference between the spinal needles and epidural needles. Spinal needles is color code, and Tahoe needle, the needle is just wide bore and has a curved ending. Here the spine in this picture, we see that the needle will penetrate the skin, subcutaneous fascia, ligamentum flavum, and the dura mater, and reach the intrathecal space, which is contain the CSF. In epidural anesthesia, the needle will penetrate the skin, subcutaneous tissue, ligamentum flavum, and reach the epidural space. It not penetrate the dura. In local anesthetics, we have either lignocaine or xylocaine or bupivacaine. Lidocaine, the maximum dose of it is 3 mg per kg without adrenaline or 7 mg per kg with adrenaline. In common properties is early onset, short duration, better sensory block than motor. In bupivacaine, maximum dose 2 mg per kg, long lasting and cardiac toxic, so must be not used IV. Local anesthetic system toxicity. The systemic effects of local anesthetic agents are dose dependent and manifest as sudden alteration in mental status, severe agitation or loss of consciousness with or without tonic-clonic convulsions, cardiovascular collapse, sinus bradycardia, conducting blocks, asystole, and ventilator tachyarrhythmia may all occur. So, skilled personnel, resuscitation equipment, and oxygen should always be available with local anesthetic use because of the potential risk of life-threatening complications. Local anesthetics toxicity may occur sometimes after an initial injection. Immediate management of local anesthetic toxicity is stop injection of local anesthesia, call for help, maintaining the airway, and if necessary secure it with a tracheal tube, give oxygen 100%, and ensure adequate lung ventilation, confirm or establish intravenous access, control seizure, give benzodiazepine, thiopental, or propofol in small incremental doses. Treatment in case of cardiac arrest, so start CPR. If there is no cardiac arrest, so stabilize the disturbed hemodynamic state by treatment of hypotension or bradycardia. During that, start intravenous lipid emulsion. Give an initial intravenous bolus injection of 20% lipid emulsion, 1.5 ml per kg over 1 minute, then convert to an infusion at a rate of 0.25 to 0.5 ml per kg per minute for 20, 30, or 60 minutes, or until hemodynamics stability is restored. Once the patient attained hemodynamic stability, the infusion should be continued for at least 10 minutes longer. Post-operative management. The post-operative period begins from the time the patient leaves the operating room and ends with the admission to the surgical ward. And the post-operative management is provided by recovery room or post-anesthetic care unit or intensive care unit. The recovery is started in the operative room, then the patient will be sent to the recovery room or post-anesthetic care unit to complete the recovery and kept there under supervision of well-trained anesthetist or nurse. Then the patient will be sent to the ICU if the patient needs further monitoring or management, or sent to either surgical wards if fully oriented, stable vital signs, limited pain, urine output is more than 0.5 ml per kg per hour, or elderly score is 9 or above. In elderly score, we have the activity, respiration, consciousness, circulation, and oxygenation. If the patient is able to move 4 extremities, voluntary or on command, the score is 2. If the patient is able to move 2 extremities, voluntaries or on commands, score is 1. If the patient is able to move no extremities, voluntary or on commands, score is 0. About respiration, if the patient is able to breathe deeply and cough-freely, score 2. If there is dyspnea or shallow or limited breathing, score is 1. If the patient is apneic, score is 0. About consciousness, fully awake, 2. Arousable on calling, 1. Not responding, 0. About circulation, blood pressure plus minus 20% of pre-anesthetic level, score is 2. And blood pressure plus minus 20 to 50% of pre-anesthetic level, score is 1. If blood pressure is plus minus more than 50% of pre-anesthetic level, score is 0. About oxygen saturation, if the saturation is more than 92%, score is 2. If the saturation is more than 90%, with the use of oxygen, score is 1. If the saturation less than 90%, with the use of oxygen, the score is 0. Criteria for administration to ICU. Critically ill, unstable patient if in need of intensive treatment and monitoring that cannot be provided outside the ICU, like post-operative respiratory failure, require mechanical ventilatory support, and shock, or hemodynamically unstable patient receiving invasive monitoring and or vasoactive drug. Patients require intensive monitoring and may potentially need immediate intravenous, like patient with chronic comorbid conditions. Post-operative management composed of continuous monitoring of vital signs, ensure secured airway with good ventilation and oxygenation, relief of post-operative nausea and vomiting, relief of pain and anxiety, keep the body warm, maintenance of body fluid and blood volume by proper fluid and blood infusion, assess the surgical site and the drain for early detection of bleeding. The delay emergence. Definition of delay emergence is a failure to regain consciousness as expected within 20 to 30 minutes of the end of surgical procedure. Causes: residual drug effect, absolute or relative overdose, potentiation of agent by prior intoxication, organ dysfunction, renal or liver, interfering with metabolism and excretion. Second, hypercapnia and or hypoxemia. Third, hypothermia below 33 degrees centigrade. Fourth, metabolic disturbance, in which hyperglycemia acid-base like hyponatremia, hypercalcemia, hypomagnesemia, five neurological insults like increasing intracranial pressure and perioperative stroke. Diagnosis: check ABG for PaO2, PaCO2, glucose, and electrolytes. Consider neurological insults. Perform pertinent neurological exam. Consider further workup, for example, CT, MRI, EEG. Consider a neuroconsult. Treatment: ensure adequate oxygenation, ventilation, and hemodynamically stable first. Administer reversal agent like naloxone for narcotic overdose, flumazenil for benzodiazepine overdose, and neostigmine for muscle relaxant. Ensure patient in normothermic. Thank you very much. This is the end of our lecture.